So I'll continue the theme that I initially spoke on, which is heart failure with preserved ejection fraction. I didn't realize they only wanted one case, so I have a number of cases, but they're very short. So I'll try to keep it to less than 12 minutes even, 11 minutes. All right. So the first case is, I'm on inpatient service right now. I just got a break for a day. So all of these are actually cases of patients in the hospital and real people. So a 64-year-old woman with diastolic heart failure comes, as they often do, with worsening volume overload. As an outpatient, she had a normal serum creatinine level and was placed on furosemide 160 milligrams orally 3 times a day, and metolazone, a thiazide diuretic. Her renal function worsened to a creatinine of 2.5 milligrams per deciliter, and they had to go to the extremes of placing her on weekly intravenous furosemide infusions. So this was last Friday. She was she saw my mentor, Michael Fowler, in clinic, and he admitted her to me and said, oh, she's probably going to need dialysis. So I'd like to make this as interactive as possible, and I can fill in for myself if you don't have any input, but what would you do in this setting? Stop everything, okay? That's certainly a possibility. She's over-diuresed is one consideration. She is in heart failure. She's volume overloaded. Her husband will say that she's 20 pounds up. All right, so I think that it's a difficult situation, and I think the first pitfall that you can have potentially in patients with diastolic heart failure is underdiuresis, and I think this is tough, especially to deal with as an outpatient. But we know, as I mentioned before, that patients with diastolic heart failure have a really narrow window for diuresis. You take too much fluid off, they lose their preload, and their renal function goes up. But if they have one more hot dog or one more pizza, then they could go the other way. So it's very difficult with these patients. And I think if the fluid is taken off very rapidly, then they could develop acute kidney injury. And so one strategy that I take with these patients, whether they're outpatients or inpatients, is to diurese them, but try to keep the rate on the slower side. It's tough because your hospital administrators are always going to yell at you and say, Medicare is paying for 4 days and you've got the patient in for 4.2 days. Well, sometimes you have to do what's right for the patient. And I think that the Cleveland Clinic group has shown very well and convincingly that if you can decongest these patients and get their CVP down and get their intra-abdominal pressure down, the renal function can actually improve. And so this patient who is still in the hospital and I will be seeing as soon as I drive back to Stanford, I put her on 3 of bumetanide 3 times a day, and she lost about 20 pounds so far during her hospitalization. Her creatinine came down to 1. We were a little bit greedy and did over-diurese her, so her creatinine's up to 2 now, but she's much better, and I think now we have some cushion to allow her to leave hospital. All right, another case, a 53-year-old woman who we just discharged actually, came in with preserved ejection fraction, high blood pressure, malaise, and orthopnea. On exam, she was grossly volume overloaded. We've never met her before, but her JVP is probably 10 centimeters above the sternal angle, and her heart rate's not too bad. It's 110 to 120 beats per minute. Her EKG showed atrial fibrillation. How do you approach patients with diastolic heart failure and atrial fibrillation? Any differently than any other patient? Yes, so I'm seeing some nodding heads. I guess maybe I could make the question easier. Are you more aggressive with patients with diastolic heart failure and atrial fibrillation or less? I'm seeing nodding for more. And I think that's the point of this case, that I'll emphasize that patients with preserved ejection fraction have decreased diastolic filling. And they're prone to atrial fibrillation, which you know as well as I do, because they have comorbidities like renal insufficiency, advanced age, and hypertension that convey a higher risk of atrial fibrillation. And I think this is, again, where guidelines can be not very helpful, because there was a big study in 2008 that came out in the New England Journal suggesting that in a large cohort of patients with heart failure, if they had atrial fibrillation, that sending them into normal sinus rhythm was not beneficial. But there are always exceptions to the rule, and I would say that acute decompensated heart failure is one of those exceptions. If a patient comes to my CCU and is in rapid atrial fibrillation, I don't say, well, AF-CHF trial, we're going to keep you in AFib. No, we cardiovert that patient. And similarly, we cardioverted this patient. And her heart rate wasn't that fast. It was 100 and 110 beats per minute. She had a TEE because we didn't know how long she'd been in atrial fibrillation, but her heart rate dropped to 70 beats per minute. And after 30 pounds of diuresis, we discharged her on Monday. So I think that another caveat I would say is don't avoid treating the atrial fibrillation. I have a lower threshold for converting those patients to sinus rhythm if they have diastolic heart failure. Another case, 68-year-old woman. This was my clinic patient, actually. Diastolic heart failure, dyslipidemia, hypertension, and diabetes. She presented to the hospital with malaise, and I got called by the general cardiology service about how I wanted this patient managed. She was in normal sinus rhythm, but did have volume overload, and her laboratory evaluation was unremarkable. But when I went by to see her in the emergency department, she said, I do have this pain that makes cramping in my legs whenever I walk. My brother just had a heart attack at age 40, and I ran the ASCVD calculator, which has become in fashion now, and her risk was 47%. And I think one point I wanted to emphasize is a point that I emphasized in my initial presentation, that patients with preserved ejection fraction have a high prevalence of coronary disease. And the problem is that these patients, I think because of some of their comorbidities, including diabetes, may not have the typical symptoms that you would see, like crushing chest pain in patients with myocardial ischemia. They may have actually heart failure symptoms. Their initial presentation may be heart failure for their ischemic event. And so the guidelines recommend an ischemic evaluation. I would go further. I think that patients usually with diastolic heart failure need a invasive ischemic evaluation, if possible. And some people would recommend coronary angiography. I think we have improving technology, as Dr. Palmas just mentioned, and so you could use CT coronary angiography on patients like that. You have to be careful because depending on your interventionalist, they might be very aggressive. And so the patient did go to the cath lab at my request, and her wedge was 25, but I think it was 25, not because I'm a terrible cardiologist, at least I hope so, or I hope not, but because she was having an acute ischemic episode. And she had 4 stents put in. I don't think any of them were Palmas stents, but they probably used the patent. And so they were all synergy stents. I have no idea what that means, but someone can tell me. But in any case, I think it was a good learning point for me that I need to be aggressive about screening these patients with diastolic heart failure. I don't know, Dr. Abraham, at Ohio State, what is the typical screening for ischemic disease for diastolic heart failure?
Yeah, no, we share your bias as well, and usually move on to invasive angiography.
Invasive, okay.
Yeah.
Good.
Yeah.
All right, this is a fun case. When I was a young CCU attending, starting out, a 69-year-old man came in, this was about 2010, with a restrictive cardiomyopathy. He'd been seen at one of our satellite, or one of our partner institutions, I think it was Kaiser actually, and they had noted that he was worsening. His VO2 max was very low, and he was actually hospitalized for inotropes and worsening renal insufficiency and put on the transplant list. He did okay, his creatinine was 1.9, but then it started worsening. As I think that there are limits to our ability to diurese patients, and so they tried to diurese him. They put a PA catheter in, and his renal function worsened to 2+ milligrams per deciliter with a very low cardiac index. When I saw him, he looked fine. He was smiling, but his creatinine was 2.6, so I was not smiling. And his cardiac index, interestingly, was greater than 3, with a CVP of 30. So this man's on the transplant list. We're trying to get him to transplant. What options do you think that we have in this case? And what would you consider for this patient? More medical therapy, more diuresis. I'll show you his echo. Maybe it'll be somewhat helpful. And I think what we were struck by was, wow, his ejection fraction is pretty good, right? I mean, this is a guy who's doing really well. And I think but sometimes I think we can be misled, as I mentioned before, and I think one of our colleagues had asked a very good question about lowering heart rate. Someone like this has a really fixed stroke volume, and I think that we can try inotropes as much as we want, it might increase the heart rate, which might actually reduce diastolic filling and reduce cardiac output. And anyway, its cardiac index is 3. So I think one other point I wanted to convey, and again, I'm interested in mechanical circulatory support, is that these patients do have MCS options. So there are multiple options available. There are temporary mechanical circulatory support like the Impella, which I don't know if you've heard about in the interventional talks, or the TANDEMHEART. There's more permanent options like the 50 cc total artificial heart that's coming out, hopefully. And in select cases, you can actually put a smaller permanent VAD, the HeartWare device, which is a continuous flow device, in patients with restrictive cardiomyopathy. We had a patient who had amyloid, but the amyloid was only found on the core from the LVAD ex post facto. We probably wouldn't have put the LVAD in the first place, but that patient actually survived for 3 years. So in any case, this patient worsened overnight. Creatinine was 2.8 milligrams per deciliter. The LV was hyperdynamic, as I mentioned, and we weren't sure that increasing the heart rate was going to help further, so we looked at all of our options. We thought about a continuous flow LVAD, but this man, was already on the transplant list. We were really trying to get him to transplant without another sternotomy. We could try an Impella, but I showed you how small that ventricle was, and I think every institution is biased about which temporary support they use. We tend to avoid the Impella because it moves around all the time. We had a patient who was getting a chest x-ray and they lifted him up and the Impella fell out of his aorta. So we actually like the TANDEMHEART quite a bit, particularly in patients with diastolic heart failure, because remember, it's an unloading device, as I mentioned earlier. The cannula sits directly in the left atrium, so it's relieving your left atrial pressure. And so that's what we thought we should do. And this is just an illustration of the TANDEMHEART again, unloading the left atrium and pushing the blood back into your femoral artery. 3 days later, he got an offer for a heart transplant. His creatinine had come down to 1.6 milligrams per deciliter, and happily after transplant, despite the immunosuppressive medications, his creatinine was 1.5. So I hope that's a brief and quick overview of the many options that we have in terms of treating our patients with diastolic heart failure, and I'll be happy to take any questions.